The regulation of gastric secretion is divided into three phases: the cephalic phase, gastric phase, and the intestinal phase. The cephalic phase is initiated by sight, smell, and taste. Images seen by the eyes stimulate the cerebral cortex. Smells entering the nose stimulate the olfactory nerve, which in turn directly activate the cortex. Food entering the mouth stimulates the medulla oblongata, which activates the thalamus. Signals from these different stimulated centers are transmitted through the dorsal nuclei of the vagal nerve to the enteric nervous system of the stomach wall and gastric glands. Let's take a closer look at the body and antrum of the stomach. On the right is the antrum of the stomach, while the body of the stomach is shown on the left. First, let's focus on the body of the stomach. Nearly all gastric secretory nerves release acetylcholine, or ACH, as their neurotransmitter. Acetylcholine binds to M3 receptors on parietal cells and activates the second messenger, inositol triphosphate diacylglycerol, or IP3-DAG. This increases intracellular calcium and causes hydrogen ion secretion into the lumen in exchange for potassium. When acetylcholine binds to its receptor on enterochromaffin-like cells, or ECL, it enhances the release of histamine. Histamine then binds to H2 receptors on parietal cells and causes cyclic AMP levels to increase. This results in acid secretion through proton pumps as they exchange hydrogen ions for potassium. The gastric phase is initiated when food enters the stomach. Distension of the stomach activates stretch receptors, initiating long vagovagal reflexes and short local reflexes mediated by the enteric nerve plexus. Released acetylcholine binds to its receptors on G cells in the antrum to induce the release of gastrin. Gastrin then travels through the circulation to the body of the stomach, where it binds to cholecystokinin B receptors on both ECL cells and parietal cells. Gastrin enhances the release of histamine from ECL cells. Histamine then binds to H2 receptors on parietal cells, causing cyclic AMP levels to increase, resulting in acid secretion. Binding of gastrin to receptors on parietal cells activates IP3-DAG, leading to increased intracellular calcium, thus also contributing to the secretion of acid. In the intestinal phase, the duodenum becomes distended when chyme enters from the stomach. This triggers the release of intestinal gastrin. Let's take a closer look. Gastrin then travels back to the stomach. To stimulate ECL cells and parietal cells, to increase acid secretion. Let's now review the inhibition of secretory processes. The presence of high levels of hydrochloric acid, and thus a low pH in the lumen of the stomach, stimulates D cells in the antrum to release somatostatin. Somatostatin then binds to its receptors on ECL cells to inhibit histamine release, thus resulting in decreased acid secretion. Somatostatin also has receptors on parietal cells. When it binds to these receptors, somatostatin inhibits the release of calcium and cyclic AMP, thus decreasing parietal cell acid secretion as well. Somatostatin also binds to G cells and causes them to decrease gastrin release. The release of gastrin from G cells is also directly inhibited by high levels of hydrochloric acid and the low pH within the gastric lumen. Let's proceed to the small intestine. Increased acidity in the small intestine causes S cells in the duodenum to release secretin into the circulation. Secretin travels to the pancreas. And causes it to secrete fluid rich in bicarbonate. Bicarbonate is then released into the duodenum. This is the main mechanism by which acid is neutralized in the duodenum. Let's now review the pharmacological agents used to reduce the effects of hydrochloric acid. H2 receptor blockers, such as cimetidine and ranitidine, reduce acid secretion by preventing histamine from binding to H2 receptors on parietal cells. Proton pump inhibitors, or PPIs, such as omeprazole, block hydrogen-potassium ATPase, or the proton pump, thus inhibiting the secretion of acid. Increased acid levels induce damage by hydrolysis of mucosal proteins, which results in mucosal erosion and ulcerations. This process is inhibited by sucralfate, which is also known as carafate. In an acidic environment, sucralfate creates a protective barrier over the gastric mucosa. It adheres to epithelial cells, thus covering ulcers and preventing further damage. Let's now proceed with the effects of antacids. Antacids such as magnesium hydroxide, aluminum hydroxide, and calcium carbonate are weak bases that react with hydrochloric acid in the stomach. They raise the luminal pH by neutralizing acid in the gastric lumen. Antacids are commonly used to treat gastric and duodenal ulcers, as well as GERD.